TopMedTalk.
Hello and welcome to TopMedTalk. We are here in Singapore for the 2024 World Congress of Anesthesiologists. I'm Desiree, Chappell, your host, and I'm joined by the co-editor-in-chief of TopMedTalk, Mike Grocott. Hello, Mike.
Hi, Desiree. Good afternoon.
Day 3 of the Congress. Phenomenal meeting so far.
Very special. Very special. Enjoyed yesterday evening, the main Congress event for faculty. Particularly enjoyed the sand painting. Don't know if you got to see all the sand painting.
I did. That was cool.
Very lovely.
Yeah, it was really nice. The whole event was beautiful. I know everyone was very appreciative of it. The food was good and entertainment was good. But just the camaraderie and networking that's been going on is fantastic.
It's been a brilliant few days.
Yeah.
Sadly, we all got to go home.
I know.
Right.
I know. Well, you've been busy.
Yep. Another session this morning. Really interesting discussion with TJ Gann from MD Anderson and Danny Levitt, my colleague in Southampton, on preparation for surgery, prehabilitation. Interesting discussion around multimorbidity and what that means to us as anaesthetists and perioperative care docs. So, yeah, very good.
Well, good. Well, we're so excited to be here in person because we're able to catch up with friends and fan faves, really, from TopMedTalk. Tim Cook from the UK. Hey, Tim, how are you?
Desiree, lovely to see you and to listen to you. And Mike, lovely to see you as well.
Good to catch up.
And just on TJ Gann, so 43 years ago, I was sitting in a maths class with TJ. We were at school together. So I didn't even know he went to do medicine. And now I found him in Duke being a professor. Yeah.
Oh, really?
Yeah. So
no kidding. Fun little fact.
Maths together at age 16, yeah.
I'm going to have to ask him about that next time I see him. Well, Tim, I think it's been a while since we've caught up, like COVID time.
Yeah. We had some interesting chats in COVID.
We did.
We lost our minds back. It was interesting time, but really tough time for many people.
It was a very tough time. A lot of learning that was going on. And I know for you personally, it was a bit of a tough experience.
So the first 3 months, I got sent home by my department because I was deemed to be high risk. And then I actually spent some time working out that I wasn't high risk and trying to get back to work, which I did after 3 hours. But during that time, I was fortunate enough to be able to effectively spend my time supporting local work at the hospital, but also learn more about the disease and therefore do a little bit of stuff centrally. And so it was ironically both, very interesting as well as learning about a new disease. It was interesting as well as incredibly challenging for all sorts of guests.
So I know before COVID, we met and we were talking about NAP.
Yeah, the National Audit Project.
Not sleeping, the National Audit.
Correct. Some people, they're named to sleeping, and the latest one's really quite big, so it's a useful pillow. But I know they're National Audit Projects, misnamed, but they're large observational studies of major complications of anaesthesia and perioperative care.
Yeah. Walk us through kind of the history of that audit.
Okay, so we're now on NURB 7. We just completed NURB 7. The topic for NURB 8 will be announced in the next few weeks. And NURB 7 studied perioperative cardiac arrest. My involvement started with NAP 3, and NAP 1 and NAP 2 were actually somewhat inward-looking audits of local anaesthetic practice in the UK. But NAP 3 studied major complications of perioperative central venous axial block, NAP 4 airway management, NAP 5 unintended awareness during general anaesthesia, NAP 6 life-threatening perioperative anaphylaxis, and NAP 7 brings us to perioperative cardiac arrest. And what they do is they've evolved over time, or developed over time, and they have a fairly consistent structure now, which allows us to look at how anaesthesia is delivered in the UK across the board. So they don't just study the topic of focus, but they really do a census of anaesthesia care, which we've now been able to track over a period of 10 or 15 years. They allow us to learn what anaesthetists and sometimes intensivists and emergency physicians think about the topic we're going to discuss and their experiences of it and hospital preparedness for events. And then we establish a registry looking at rare complications. And the registry allows us to look at the sequelae of roughly 3 million anaesthetic episodes. So they're big studies. They look at rare events and they look at events that could not be studied usefully by a randomized controlled trial, which is why they have value.
Yeah, absolutely.
So from the Royal College of Anaesthetists and other organisations supported, aren't they? And my understanding's always been that the NAPs are about the rare but consequential, in contrast to, say, there's SNAPs or PQIP, which are more about the the run of usual care and
Correct.
major complications, that kind of thing.
Correct. So the criteria for firstly, yes, they're Royal College of Anaesthetists projects. So NAP5 was co-funded and co-produced by the Association of Anaesthetists, but they have buy-in and involvement of a huge number of stakeholders. So we had about 15 different stakeholders, and of course, lay public involvement in throughout the projects, in that both in the planning and prosecution analysis and reporting of the projects. So in order for a topic to be accepted for a NAP, it has to be a complicational problem which is relevant for patients. If it's not relevant for patients, why study it? It has to be relevant for anaesthetists, because most of the work is done by anaesthetists doing their normal job, reporting cases to us. They have to be engaged. And if they're not engaged, and actually the engagement of Anaesthesia UK in these projects is something that I think Anaesthesia UK can be really proud of across the last 15 years. And perhaps has had spin-off effects into anaesthetists being more involved in healthcare research subsequently. So they have to be interesting, important to patients, important to anaesthetists, incompletely understood. We often reject central venous access because we think we know enough about that already, not worth studying. And events have to be so infrequent that you couldn't study them more usefully by randomized controlled trials. So so there are lots of randomized controlled trials that are better methodology than the NAPs, but you couldn't study the events. We're sometimes looking at an event that happens. So typically the events will happen 1 in 10 or 1 in 20,000 cases. So they are what we call coffee room events. They're events that might happen in a reasonable sized hospital once a year. Everyone will discuss them. You do an M&M on them. You might learn from them locally. But by doing national M&M, by doing a NAP that brings together several hundred of these events, you can both analyse them numerically, quantitatively, look at the proportion of X and Y and Z, but also you can look at the themic analysis, so qualitative analysis. And very important to them is that we don't just, so they're called the national audits, they're misnamed, they're service evaluations. A lot of audits will simply try and identify events, whereas we have a phase which is really important, which we identify a denominator. So we have a main section of the project is to do a national survey of anaesthesia activity, so essentially getting information from every case done in the UK for, in this case, 4 days. And in this case, we found out who did what, when, where, to who, what the specialties were, to a certain extent how anaesthesia was delivered. And then we measured complications over that time. So we have a denominator in depth, a very rich database of denominator data against which we can then compare our registry. So we can say the incidence of perioperative cardiac arrest is 1 in 3,000, as it turns out. We can say for the elderly and the frail, it's 1 in 1,000.
Because you have all of that.
ASA1 patients, it's 1 in 11,000.
Oh, interesting. So remind me again, I might have missed this. It's self-reported?
Self-reported, yeah. So the way it's organised is the college funds a central panel, which is both a steering group, a review group, an analysis group, a writing group during what is usually 4 years of the project. Of course, this project took place across the period of the pandemic as well, which we might discuss. And then within each hospital, there is a local coordinator. So every hospital in the NHS, in the National Health Service, had a local coordinator who would be the eyes and ears and hands and feet on the ground that would make the project work, disseminate the project and coordinate the project locally. And then any anaesthetist would be involved. So at one phase of the study, I think there were about 16,000 anaesthetists in the UK. For one phase, we had just over 11,000 anaesthetists individually reporting to the project, like 2 phases. So that's about 70% of all UK anaesthetists actively involved in the project. So the numbers are big.
Yeah, they really are.
The resource that you must have from the censuses, if you like, occurring sequentially over time, what are your reflections having looked at those sets of data coming in every few years?
Yeah, so we only started it. So as I say, the projects have evolved, and we've only had a census since NAP5, which was 10 years prior to the data we collected for NAP7. So we were able to compare changes over the 10 years. We've looked at that. So you can actually look in quite a lot of detail. So we've got 26,000 cases for the NAP7 census. And we can compare that to the 20,000 odd cases we had for NAP5 and look at trends. So, for instance, it's very clear that across those 10 years, the patients that we anaesthetise, I think everybody has a lot of what the NAPS does is it puts into numbers things that we kind of already sense, we already know. We can say, actually, yeah, this is what the numbers are. So we know that in over the last 10 years, patients that present for anaesthesia become 2.3 years older. And so anaesthesia patients are getting older at a faster rate than the population is. For every year that you age, your mortality increases 10%. Your all-cause mortality increases 10%. So we're now anaesthetising a population which on average has a 25% mortality risk for all causes, 25% higher than it was 10 years ago. Add to that, there's been a marked increase in obesity. So the average BMI of patients has gone from the normal range to the overweight range in the UK. So it's about 27.5 now. And if you divide the cohorts, the BMIs into normal range and then obesity 1, 2, 3, then the greatest increase has been in the most obese patients. And so not only has the proportion of obesity increased, but the extent of obesity has increased. And then on top of that, if you look at this change in ASAs, there's significant increases in the higher ASAs. So we are anaesthetising to put it bluntly, an older, fatter, less fit cohort of patients. We're running to stand still. So any metric we have of how we're performing has to be judged against the fact that our population has changed. And we kind of know that, we kind of know that already.
Like you feel that.
Now NAP 7, you can say, well, these are the numbers.
So that reflects absolutely what I experience in Southampton, a major teaching hospital. Is some of that the farming out of lower risk cases to places where you might not be reaching with the NAPs, so the high volume, low complexity hubs?
It's possible. So we make strenuous efforts to reach those patients. So for listeners who are not necessarily from the UK, about 90% of UK practices is within the NHS and 10% in private sectors. It varies within the region. But we try and penetrate the independent sector with the NAPs as well. We have less success, less returns, but not because of less effort. So there may be some elements of that, but I think because the vast majority of work is done in the NHS, I think those figures probably still stand. I mean, there are other trends as well that we notice. So we notice changes in practice. We notice change. So there's been a 4-fold increase in the use of total intravenous anaesthesia those 10 years. So it used to be 8%. It's actually 3-fold. It used to be 8%. It's now up to 25% of all anaesthetics. Changes in monitoring, increased use, probably paralleling that, increased use of process EEG monitoring, and various other trends in practice that have happened over the time, which we can map.
Yeah,
very interesting.
It is very interesting. So, okay, so let's talk about NAP 7. We saw you yesterday. The first thing you're like, it's just so much data, which is a great thing.
Yeah, it's all numbers. All numbers. I have a challenge every time I'm part of a NAP. I say we want this to be more concise. We want fewer recommendations, and it just needs to be thinner. And each time it gets bigger and bigger. This time, the good news is there's no actual book. So, there's an ISBN. Everything's available online, as it always has been.
Right.
So if you just search NAP 7 and report, you'll go to the report and all the individual chapters, all online. If you search NAP 7 and RCOA, you'll go to all the papers and the full report. It's about 500 pages long, but it's got 40 chapters, 39 chapters, each of which are fairly well circumscribed and focus on a particular area of practice. And I would challenge anybody I would say that for every anaesthetist, there will be 3 or 4 chapters which are directly relevant to them and which will have directly relevant information, as well as the general chapters.
And is this for any anesthesia? I mean, outside of the UK, or do you have to have access within?
I think, so it's a UK project. It's done by Anaesthesia UK. It's from college. But it's open. It's the access. Yeah. So the access via the college is open. I thought you were going to say, is it relevant to it?
Oh, yeah, no.
So access to the website, yes, anybody can access it. Yeah. Just Google it. And then we've partnered with the journal Anaesthesia this time, and they've been fabulous supporters. And they have published so far about 12 papers. It'll end up about 18 papers, all of which are free access.
Free access, that's great. And I'm sure there's much to be learned for all of us anesthesia clinicians in that. So what were some big takeaways? Well, I think one of the things that's interesting is, so one of the slides I have is I say, okay, so for the previous NAPs, we've got these instances. One's 1 in 120,000, one's 1 in 15,000, one's 1 in 18,000, one's 1 in 3,000. Which of them is
complications of spinal anaesthesia. Which of them is dying during operation, which is what perioperative cardiac arrest is. It's dying during your operation unless you're resuscitated. So the criteria for NAP7 was you had to have a cardiac arrest, require CPR for at least 5 beats, or defibrillation. So effectively it is dying during the operation and then being resuscitated in most cases. So which number fits which case? And so, for instance, awareness during anaesthesia is about 1 in 15,000. Fatality associated with airway complications maybe 1 in 140,000. Complications, permanent complications of a spinal anaesthetic, 1 in 50,000. And these are the things that people worry about. Having a cardiac arrest during anaesthesia, 1 in 3,000. An order of magnitude higher. So yes, that's all comers. That includes your emergency aneurysm that's coming in the process of dying.
Yeah.
But when you divide it down, as I said, so you can take it down. So we have essentially the numerics for all of this. So if you look at a fit and well patient, so an ASA1 patient, the incidence of cardiac arrest is still around 1 in 10,000.
Oh my goodness.
The resuscitation rate, so the immediate, so ROSC, return of spontaneous circulation at the point of that arrest, is probably about 92%.
Okay.
All comers, the incidence is 1 in 3,000 cardiac arrests and resuscitation rate 75%. And then if you go to the other extreme, you go to the elderly and the frail, so people have a clinical frailty score of 5 and above or age over 75, their overall incidence of cardiac arrest is 1 in 1,000 with 50% mortality. So you can look at all these different groups and you can either take the relative things and say, okay, how much greater is that risk than that? How much greater is the survival response? But also you can look at the absolute numbers and say, well, actually, we talk about these elderly, frail patients. We're saying, well, look, they're 20-fold more likely to have a cardiac arrest and twice as likely to die if they have a cardiac arrest.
Yeah.
But actually, their absolute risk, 1 in 1,000. So it's actually relatively low. So you have these figures which you can then look at and work around. But within each of these, for every statistic I give you, there will be a qualitative discussion around cases and events. And so there are 3 phases. The first phase of the project is the baseline survey looking at preparedness of departments, and departments are pretty well prepared for cardiac arrest, but somewhat deficient in preparation for pediatric cardiac arrest. And it looked at individual experiences. So there are probably 3 things to say about individual experiences of cardiac arrest. Firstly, most people it's going to be, I don't know, 3, 5. Most anaesthetists have had them in the last 2 years. Their expectations of the anaesthetist's belief of what causes cardiac arrest and their actual experiences differ. And then the actual, in the registry, what actually were the commonest causes of cardiac arrest, again, differ. So anaesthetists are very keen on thinking cardiac arrest due to anaphylaxis, and it's far less common than anaesthetists think it is. So maybe a get out of jail card.
To stick a pin in this for just really, because that kind of caught my attention just a little bit. So thinking that, it's something different than what reality is.
Yeah, so we asked anaesthetists, I'll come back to a couple of things from the baseline, but we asked anaesthetists what they thought the 3 most common causes of cardiac arrest were, and their top 3 were hypovolemia, hypoxemia, and ischemia, with anaphylaxis 4th. And then we asked them what their most recent, for those anaesthetists, which was 45% who'd attended a cardiac arrest in the previous 2 years, what was the cause? And they were quite different. They were hemorrhage and then anaphylaxis at 10% and cardiac ischemia. So some overlap, but
a little bit,
but not. And then when we looked at actually in the registry the causes, then hemorrhage was very much the top.
Yes.
Bradyarrhythmias, which I think a lot of anaesthetists forget because they're not trivial cardiac arrests. I don't think the patient would think they're trivial. They're the arrests with the greatest survival rate. They're usually transient and well treated.
Let the normal peritoneum down.
Yeah, and then cardiac ischemia was the 3rd. And anaphylaxis was only 4% of cases, so estimated as 10% by anaesthetists, but actually only 4%.
Small percent.
And it may be that it depends what your specialism is. So, for instance, if you're only doing general surgery or abdominal surgery, then the most common cause of cardiac arrest is septic shock.
Mm-hmm.
Whereas if you're doing cardiac surgery, it's cardiac ischemia. If it's ENT surgery, the commonest cause of cardiac arrest is profound hypoxemia. And if you're involved in the pelvic surgery, not surprisingly, bradycardia.
Yeah.
So it all depends.
Oh, that's fascinating. Mike, what do you think about that?
I'm most intrigued by the data you presented earlier, the perception, reality,
the disconnect,
the mismatch, that disconnect. which I guess it's not that surprising, but good to see
No, there's nothing
concrete data about it.
There's nothing surprising in the naps. It's stuff we all know, and then you go, but those numbers don't make sense. So the nature of the cardiac arrest, so the vast majority are, so 17% required defibrillation, 12% were primary shockable rhythm. We all do mandatory training, which is all focused on defibrillation. Very few of us, if you're not doing obstetrics, do mandatory training on management of major hemorrhage. We will be expected to know it, but we don't do mandatory training on it. But hemorrhage is the primary cause of cardiac arrest in theatre. So hemorrhage can happen in all specialties, but only amongst the specialties we looked at, although hemorrhage was the single primary cause, it's only 17%. So there are lots of primary causes. So even though it's the commonest, it's not half of the cases. So it's about a fifth of them. But it can happen in any specialty, and it happened in young, fit, healthy patients undergoing relatively minor surgery. It was only the primary cause in a subspecialty in obstetrics and vascular, actually. Vascular.
Okay, makes sense.
But it can happen. There was quite a lot of, so when we looked at the quality of care, most care intraoperatively and postoperatively, post-event, was extremely good. In about a third of cases, there was substandard care or poor care.
Unrecognized?
Prior to events. And that would include, that was across the board, but that would include hemorrhage. So the areas that we can focus on are improving care to prevent perioperative cardiac arrest, particularly.
Mike?
What comes next? What are the consequences of all this? What does the recovery pattern look like? What are the recovery rates? So you've told us about the sort of what's the causation? Something about the incidents, but what if that will lead to?
But it all depends where you are having your cardiac arrest. Remembering that only about half of the cardiac arrests occur in main theatres. A lot of them occurring remotely, and obviously a lot of them emergencies. But the overall ROSC rate is 75%. So 3/4 of the patients who have a perioperative cardiac arrest will get a return of spontaneous circulation. At the point that they are reported to NAP7, 56% of patients were still alive. So with the mortality, you can roughly say that half the deaths from perioperative cardiac arrest will occur at the time of the arrest, and almost the same number before they leave hospital. It was a good outcome was that 92% of patients went to critical care. And we're talking, there was 881 patients that we studied in the year, so that's about 3 patients per hospital per year. So we're good at getting them to critical care when we need to. And of the patients, so we looked at their MRS, their modified Rankin score. We tried to capture that beforehand and afterwards. Those patients that left hospital, 88% had a modified Rankin score of less than 3. So that means that they would live independently. So in broad terms, they would return to independent life. So across the board, most people who are surviving perioperative cardiac arrest, most people are surviving it. Most people who are surviving with a relatively good outcome. And there's a cohort of patients that's rather small that we looked at where we had the modified Rankin score before cardiac arrest and after cardiac arrest. And there was very little deterioration, almost all returned to where they'd been before. So I think in general, the outcomes are very, very good. You compare that to in-hospital cardiac arrest, and you've got a resuscitation rate of about 50% and a leaving hospital rate of 3%. And out-of-hospital cardiac arrest, it's about 8% overall. So it's an area, they're highly monitored patients, looked after by people who should be confident to resuscitate. Based on the study, not everybody was. And they should have good outcomes, and by and large, they did.
So remind us again, as we wrap here, Tim, all of this data, all this information, you publish it, put it in a big, book that you've done. How is it used to educate and that you're disseminating the information out there and the purpose, not purpose, but how are providers using it?
So the prime purpose of the National Audit Project is to generate information of value for patients. So when we set out with NAP3, the aim was to give better information for patients. And there's a host of information, risk information, numbers, which can be used to inform patients to say, this is the general risk, this is the average risk, which can then be used in shared decision-making. So information provision to patients preoperatively, and then so accurate and specific to their circumstance, relatively specific, that can increase the information we're giving patients, which can help in those decisions as to whether surgery is the right thing for them, what the genuine risks are, etc., etc. And we have, and one of the really interesting points that one of the lay members made during the conversations we had in the panel was, they said, we're saying, well, this is really high risk. I'm really worried about this is high risk. He said, well, you forget the risk. It's the patient that takes the risk. You don't take the risk. It's the patient that takes the risk. So providing that information is a really core piece of information. Providing that, and we're trying to disseminate. We disseminate this through publication. We've had, in 3 months, about 100 different presentations at meetings, etc. So we're trying to get the message out there. Each chapter, each of these 39 chapters, makes recommendations for that area of practice. Some of them are a bit apple pie. We don't shy away from making apple pie recommendations, but some of them are challenging and challenge institutional organisation. And then we have a chapter which has the top 20 recommendations, which is one of those chapters amongst the main chapters that I recommend people.
Yeah.
I mean, there's a chapter on the overall findings, the main recommendations. There are some really interesting chapters that people should read on risk and particularly high-risk patients.
Definitely.
We could spend a long time, for instance, there's masses on kids, etc.
The risk of minimising your tome and your hundreds of pages and your 39 chapters and all these patients.
Take-home message?
Yes, 2-3 take-homes.
The first take-home message is it's not all about cardiac arrest. These projects they do really shine a light on one topic, but they look at the whole of anaesthesia practice with 4 countries at a particular time. And the 3 sections, the baseline, where are we at, the complications and the cardiac arrest, the registry, have to come in together. So there's a lot of complexity that comes in together. I find the take-home messages difficult. I mean, at its simplest, the take-home messages are sick people are more likely to have a cardiac arrest than healthy patients, and people generally do well. But that doesn't really get to them.
Well, they do well is worth knowing. It's really worth, if you're there when it happens, that's a big deal. And the hemorrhage message, I think, is quite interesting in terms of what to think of when your patient arrests in front of you.
Yeah.
That's quite an important clinical message. Yep.
So, Tim, in closing here, what would you think is the biggest message that anesthesia clinicians need to take away from this?
I think it's difficult to condense a large report with huge amounts of data into one soundbite. And I think there will be no clinician that doesn't get something from reading the chapters that are relevant to their clinical practice and reading the generic chapters on key findings and key recommendations. And I think people will be tempted into reading more of it. So I think read the report. You've got to get in there. It's available everywhere. I think we've done our best to make it approachable, visually appealing, clear. I would strongly recommend that people have a go at reading it.
I mean, I think things like this, when we really can embrace them as a clinician, we have time to read this kind of stuff. And it sounds like it is like, as you said, it is really delivered in a way that is easy to consume and engage with.
I hope so. We've made a considerable effort to achieve that. Fantastic.
Well, Tim, if people want more information, where do they go to find this?
So if you just Google NURP7 and either report, NURP7 report, or NAP7 RCOA, which is the Royal College of Anaesthetists, that will take you to the 2 main pages. But NAP7 will probably get you there.
Yeah.
If not, go to PubMed and look for NAP7 on Anaesthesia journal pages.
And anybody in the world can read these, and it sounds like a lot of us have a lot to learn from it.
If you simply Google Tim Cook NAP7, you'll probably find it. Well, you might go to some Apple pages first.
We'll find you on there.
That's my other job.
For another podcast. All right. We'll catch you soon. Cheers. Bye.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.